Thanks for everybody joining us today. So I've been tasked with trying to cover as much as I can about radiation oncology in a nutshell in 10 minutes. Thankfully, I think a few things have been covered as we've been going, but just as a brief intro, so radiation sounds scary. I think it like conjures up like visions of the Hulk or, getting superpowers and stuff like that. But about half of cancer patients will receive radiotherapy as part of their care, and it's part of the curative treatment for a number of different cancers. It can be used in conjunction with surgery or various systemic therapies, often in the case in prostate cancer with ADT. Now, I don't have like fancy DNA diagrams like John did, but radiation essentially works by causing DNA damage. And so diagrammatically, the photon sort of hits like a particle and basically spurs on different types of actions that can damage DNA. And we take advantage of biology when we deliver radiation therapy. So normal tissues can repair this type of DNA damage. And then cancer cells are a little bit, dumber. They are programmed to grow, replicate, and so they lack the ability to repair their DNA in the same way as your healthy tissues do. The other sort of piece that we leverage in radiation that I'll talk about as well is spatial. And so geometrically, we're able to target radiation in very specific areas, and that helps us mitigate side effects that are generated by DNA damage to healthy tissues. So radiation plays a role in the prostate cancer care spectrum across a number of different settings. This session, of course, is focused on localized prostate cancer, in which case radiation, its role is largely sort of both definitive as an option up front, but also after surgery, as Dr. Cooperberg mentioned. It also plays a role in other areas. So no positive prostate cancer. We'll talk a little bit about the oligometastatic setting later on today, as well as in polymetastatic prostate cancer. When we meet with patients, it's sort of often a complex decision-making process. As a number of speakers have discussed earlier, we really participate in this shared decision-making. I think our job is kind of to review the data that surrounds our treatments and try to equip you guys with the knowledge to kind of make a calculated decision in how to proceed with your care. There are a couple of main key factors that play a role in our conversations. The first of these is to talk about risk stratification, which Dr. Washington, Dr. Shi covered earlier today, to think about each individual patient and all of the specific aspects that about everyone that we should be considering, and then kind of form a framework for the radiation therapy options, as well as the hormone therapy options for any specific individual. And at that point, I think that the decision kind of takes into consideration the different preferences and sort of trying to handle the cost-benefit decision across any of the treatment options. And then certainly we work closely with our colleagues across the multiple disciplines to come up with final decisions and to help counsel folks. And then we proceed with treatment, and then as I think Dr. Washington mentioned earlier, extensive follow-up and close surveillance after treatment for both outcomes and toxicities. All right, so this is kind of diagrammatically or a number of the different types of radiation therapy, which we can't cover, everything in 10 minutes. But I think we'll hear a little bit about radionuclides later in the day. So I'm focusing a little bit more on sort of the therapeutic radiation oncology options. The primary sort of big groups are external beam radiation therapy, as well as brachytherapy. Brachytherapy is sort of the way I describe it to folks is internal radiation. There are a couple of ways to deliver brachytherapy, both with permanent implanted seeds as well as temporary seeds that are placed via a catheter. We'll focus most of our attention today on kind of the pipeline or the process and workflow through the external beam radiation approach. We sort of split external beam radiation, frequently referred to as IMRT or VMAT. Those are things you'll find on Google. into three main sections. Historically, conventional fractionation has been sort of the mainstay in external beam radiation. That's treatment that goes over the course of up to 9 weeks with radiation given daily from Monday through Friday. Over the past couple of decades, there's been a trend towards what we call moderate hypofractionation. And so the natural question when patients were undergoing 9 weeks of radiation was, can you guys do this stuff a little bit faster? And so a number of trials showed that we could feasibly do so with similar cure rates and toxicity rates with quicker treatments, usually spanning over the course of about 4 to 5.5 weeks. And then sort of on the newer side, past couple of decades, there's been a lot of interest in what we call stereotactic body radiation therapy, SBRT. And SBRT has been used in a number of different types of cancers, brain cancers, lung cancers included, and certainly prostate cancer. SBRT is typically defined as high doses of radiation that are given over fewer treatments, usually about 5 treatments or less. And certainly has been used for prostate cancer now for a couple of decades. And then I should mention combination radiotherapy. Folks often hear about a boost, and that's done with a combination of external beam radiation, typically done conventionally fractionated, so about for 5 weeks, and then with a boost that's done using either brachytherapy or SBRT. All right, so to give you guys a little bit of diagrammatic representation, this is kind of just a couple examples, as you'll see online, that there are different ways to deliver radiation. The current sort of state of the art is what we call IMRT. And so as you can imagine, back like sort of before we did, radiation plans were done with what we call 3D conformal. And 3D plans, I like to joke that like doctors aren't terribly creative. And so the radiation beams basically came from 4 directions, 1 beam in the front, 1 beam in the back, and then 2 beams from either side. And so as you can imagine, that resulted in more radiation being delivered to healthy tissues. And then over the past few decades, there's been adoption of what we call intensity modulated radiation therapy, which is IMRT. And IMRT delivers radiation from multiple directions, and the radiation beam actually changes shape as that beam is delivered, hence the intensity modulated part. And I'll actually show a cool figure of that. And then VMAT is volumetric modulated arc therapy. It's an iteration on IMRT and typically what we use here at UCSF. And VMAT basically consists of IMRT that's delivered over continuous beams that come around as the machine is rotating around a patient. So it allows us to have a smoother dose distribution, as you can see, kind of in comparison to the other options. So when we meet with folks, this is kind of the care path that we go through. You know, we have the consultation, and then sort of when we're moving forward through radiation, there are a number of sort of paths or steps that folks go through, and then we'll talk a little bit about like the different pieces of this care path, and then the sort of different aspects that happen when someone goes through radiation treatment. So the first step is once we've decided to do radiation for localized disease, gold seed markers placed by our urology colleagues are frequently the first stop. We then proceed with what we call a simulation. I like to use the phrase radiation planning scan because it makes more sense. Simulation comes from a process that we used to do in older, older radiation approaches. And that consists of a CT scan with or without an MRI. And we really use that scan to plan out the radiation on the computer. So we trace where the radiation needs to go. And this is done on sort of the sub-millimeter level. And then we also trace out and model out the normal organs to make sure that we're avoiding those areas when we plan out the radiation on the computer. We also develop immobilization devices at this point in time, and then a couple of sort of setup things, bladder filling to help push the bladder farther away from the prostate and therefore farther away from the radiation, and then having an empty rectum, which keeps the rectum flat farther away from the prostate as well, both of those things to mitigate side effects. Once we put that scan together, we work on it on the computer. It was like probably the most exciting picture of like a doctor working on the computer that I could find. But we put the images together, do all the delineation, and then come up with a radiation plan that looks kind of like a weather map, where the radiation is focused on the target, in this case on the prostate in this picture down here that's in red. And then it basically shows kind of the lower doses of radiation that are going to things that are further out from the prostate. It goes to our medical physics team after that, and they actually test the machine to make sure that what we program in the computer actually works in real life. Sometimes that doesn't happen. And so we test everything for safety before we start giving radiation to patients. Then folks come in for treatment each day. This is just a picture of one of the immobilization devices. It sort of keeps, it's basically a glorified beanbag that we suck the air out of, and it forms the shape of your back. And that allows us to plan radiation to sub 5 mm precision, just to keep patients in the same place each day. And then the radiation machine spins around. People don't see or hear or taste the radiation. No one glows in the dark, no superpowers or anything like that. And it really feels like getting a scan done each day. Part of the treatment process is this alignment with the gold seed markers. This is just an image of what it looks like on the scans that we do on board the machine each day. There's an automatic process that allows the markers to be matched on the machine. And then we also can manually make tweaks just to make sure that everything's perfectly aligned. The scanners on the machine up here also show you like the bladder and the rectum, and so we can make sure that those normal organs are appropriately out of the way of the radiation to mitigate side effects. And then the radiation beam turns on, and it does change shape like that. As I've had some patients who are brave enough to look into the machine while it's running, and delivers the radiation each day. And then we see each other routinely from there on out. Our surveillance process usually consists of having PSA checks every 3 months, and then being stuck talking to me every 6 months at least. We manage a number of different side effects during radiation. In the short term, these are side effects that happen during the radiation and can last they peak about a week and a half or so after the radiation, and start to basically resolve at about a month or so after the radiation. These things are fatigue, and then things that are related to areas that are close to the prostate, so urine and bowel side effects. They usually kick in about halfway through the radiation course, and so for more fractionated radiation courses, it's about 3 weeks or so in, and when we do SBRT and 5 treatments, usually about kind of the second half of the treatment course. And then long-term side effects, I think, are the main, one of the most important things to consider as folks especially are making decisions about their treatment, and sort of split them into their domains. They're roughly sort of the similar areas as with surgery, with the exception of bowel toxicity, because the rectum sits behind the radiation. So one of the main things I talk to folks about is the risk of having blood in your stool, even years after radiation. So for instance, that risk plateaus at about 7 years out, which is quite some time after radiation. These are sort of the general areas of side effects that we're keeping an eye on as we follow folks in the long term. And with that, I think I can wind down. I should give a special shout out to one of my colleagues, Osama Mohammed, who prepped some of the slides that we use today. All right, the question, what is the question specifically? Do we use SpaceOAR? Okay, so some folks have heard about a rectal spacer, the SpaceOAR. There are a couple brands, but the SpaceOAR, which is a bioabsorbable hydrogel that is placed between the prostate and the rectum. We do use SpaceOAR here specifically in our stereotactic or SBRT cases. So those short courses of radiation, that's the main place that we use them due to sort of the data around it. So it helps prevent and reduce that rectal risk that I was talking about earlier.